Hi, everyone. I'm Cindy Gavin, CEO and co-founder of Let's Win Pancreatic Cancer. On today's podcast, we will take a closer look at the different treatment options for pancreatic cancer. Now, over to you, Alisyn.
Hi, everyone. Welcome to episode 5 of PancChat. Today's episode focuses on treatment options for pancreatic cancer. I'm your host, Alisyn Camerota, and we want to thank our sponsor, Revolution Medicines. So let me introduce our guest today. Dr. Michael Pishvaian is the Director of Gastrointestinal, Developmental Therapeutics, and Clinical Research Programs for the Johns Hopkins Kimmel Cancer Center in the Greater Washington, D.C. area, and an Associate Professor at the School of Medicine. Welcome, Doctor.
Thank you so much for having me.
Thanks for being here. Yeah. So let's just start with the basics, if we can. So when someone is diagnosed with pancreatic cancer, they are often offered standard of care treatment. Can you help define for us what standard of care means?
Yeah, absolutely. So standard of care really means the best that we know of to offer that patient at that given time. And we hope that standard of care improves over time as clinical trials are done. And right now, the standard of care involves primarily chemotherapy for patients with pancreatic cancer.
As I've let our audience know, I'm familiar with this because my husband passed away a year ago from pancreatic cancer. So I remember that standard of care was one option. He was lucky enough to get on a clinical trial. And I say lucky enough because is the standard of care good enough? I mean, my impression is that people are always searching for something different than the standard of care in pancreatic cancer treatment.
That's a tough question. I would say for any cancer or for any disease, really, the standard of care is never good enough until the cure rate is 100%. But having said that, we definitely have made headway in the standard of care for pancreatic cancer, but we know that we still have a long way to go. We also know that we're woefully low in our clinical trial accrual rate. We only recruit about 4% of all pancreatic cancer patients into clinical trials. So while we need to make progress, we really need to get more patients on trials to be able to make that progress.
Why is it so low, that recruitment rate?
So there's a variety of reasons. Nobody knows exactly why. One of the things that we fight against the most is the nihilism, the cynicism that comes with a diagnosis of pancreatic cancer. And even in 2025, we still hear stories of family members, physicians, primary care doctors, gastroenterologists telling patients you've been diagnosed with pancreatic cancer, don't bother getting any treatment, just go get your affairs in order, which is really, really shameful. And because of that, there's actually good data, both from Canada and from the United States, looking at insurance rolls that fewer than 50% of patients who are labeled with a pancreatic cancer diagnosis get any treatment at all. Not surgery, not radiation, not chemotherapy, nothing. So a lot of those patients, probably some of those patients are very sick and they can't get any treatment, but definitely some of those patients are being kind of guided to not undergo any treatment at all. Even of the 50% of patients who do get some sort of treatment, the lack of clinical trial enrollment definitely has a lot to do with the fact that there aren't a lot of really great clinical trials for patients. So even if we could enroll every patient into a clinical trial, we just don't have enough spots in innovative, exciting clinical trials. And then there are logistical concerns as well. Sometimes it's just practically difficult for a patient to get into a clinical trial. I think if I'm not mistaken, you're in New York, I'm in DC. We both have multiple centers near us. But for a patient who's in Montana or even in Oregon, they have to travel sometimes 6, 7, 8 hours to get to a site that might have a trial that's appropriate for them.
Wow, that's really stunning. Thank you for all of that background. I wasn't aware of how difficult it can be because, as we say, standard of care only goes so far. So with standard of care, it means chemotherapy. Does it also mean surgery and radiation? Are those part of standard of care treatment?
They definitely are part of the overall armamentarium, but that definitely depends upon the stage and what the expectation is for treating that cancer. A lot of patients will ask me about what stage of pancreas cancer they have, and I often forget if they're stage 1 or stage 2 in an earlier stage patient, because the reality is we really only focus on 3 characteristics of a patient's cancer when they're newly diagnosed. They're either clearly operable from the get-go, so they're resectable. They have already cancer that's already learned to spread to another organ, and that's a stage 4 cancer. And then there's essentially everything in between, the localized patients that have some degree of involvement of the local blood vessels, making direct surgery, more challenging.
I mean, I know that everyone is always gunning for surgery. What is and I don't know if you have this figure off the top of your head, but what's the general percentage of people who are eligible for surgery?
That's only about 10% of patients who are eligible from the get-go. These cancers learn to grow very quietly, very subtly. Patients might have just the vaguest of symptoms over sometimes months or sometimes even a year or two before the cancer actually becomes diagnosed. And so the cancers learn to spread very early on. So 55% of patients, when they are diagnosed, already have stage 4 cancer. And 30 to 35%, their cancer is already involving or wrapped around some of the critical blood vessels that make surgery very difficult.
Mm. So really, as you say, only 10% are eligible for surgery. And what is their, I mean, I know that you can't generalize, but that's the best prognosis if you can get surgery, yes?
So far to date, the only way that we know how to cure a patient with pancreatic cancer is if they ultimately have surgery, whether that's before or after chemotherapy, but ultimately surgery is the only way to cure them. Our rates of cure have definitely gone up in the last 30 years. 30 years ago, the rate of cure with surgery was under 5%, probably like 1 or 2%. With chemotherapy being given postoperatively, those rates have significantly improved. It's still only a little less than 50%. So about 40% of patients under the best of circumstances are ultimately cured with a combination of surgery and chemotherapy, plus minus radiation. There's a lot of controversy about that, but surgery and chemotherapy can achieve about a 40, maybe up to 50% cure rate in a patient with pancreatic cancer.
Let's talk about the role of radiation. So radiation, is it always used in conjunction with something else, or can it be used just alone?
It can definitely be used alone. So it definitely depends on the goal of the radiation therapy. I refer a lot of patients with pancreatic cancer to radiation therapy because radiation can be very effective at treating the symptoms that come from the tumor. So if it's a tumor in the pancreas, it can control pain and other symptoms that are coming from that tumor. If it's a metastasis that has spread to another part of the body that again is causing symptoms such as pain, then the radiation can be very effective at treating that area as well. What we don't know, even up to today, is whether radiation actually helps cure patients at all. In fact, there have been multiple studies, and we've really never proven that radiation increases the cure rate. There's a lot of secondary studies and a lot of pointing that there are some patients for whom radiation is beneficial, but we really haven't been able to nail that down. And there's many other studies that are in development or ongoing trying to answer that question definitively.
That's really interesting. So basically, at the moment, in terms of standard of care, you're using the radiation in a palliative way.
In a palliative way, and then I would say in the most selected population of patients that's being decided in a multidisciplinary fashion that's really critical, where the surgeons, the medical oncologists, and the radiation oncologists are discussing together. Sometimes we are also incorporating radiation therapy with curative intent.
Let's talk about chemotherapy. So are there many different chemotypes that you use for pancreatic cancer, or is it mostly FOLFIRINOX?
There's only really 2 types, maybe 3. I often joke with my fellows that pancreatic cancer amongst the GI cancers is probably the cancer for people who aren't so smart to learn to treat, because you only have 2 real choices. Cancers like colorectal cancer has become very complicated. Gastric cancer has become very complicated, and complicated in a good way, because you have so many things, so many different ways to treat patients. For pancreatic cancer, we're still really sort of reliant on 2 standard of care regimens, and I'll mention a third in a second. So first of all, as a background, back in the 90s, there was really very little to offer patients in terms of chemotherapy, but from the late 1990s through to the mid 2000 teens, or early 2000 teens, the only drug we really used was a drug called gemcitabine. There was another drug, 5-FU, which probably worked as well as gemcitabine, but the gemcitabine was generally better tolerated, and so we used that preferentially. And gemcitabine didn't do much. It really kind of slowed the decline of a patient, but you never really saw patients get much better with gemcitabine. But in 2011, we had the FOLFIRINOX study, which is a combination of 3 chemotherapy drugs, 5-FU, oxaliplatin, and irinotecan. And those three combined together were clearly better than gemcitabine alone. A couple years after that, we had the combination of gemcitabine and nab-paclitaxel. Many people will know it as Abraxane, but gemcitabine and Abraxane was also clearly better than gemcitabine alone. And that's really been our two standards for the last now 14 years. There's one other combination that patients may have heard of, which is gemcitabine and cisplatin, which is a combination that is appropriate to use for patients who are newly diagnosed and have the right kind of mutational status. And then finally, there's another 3-drug combination that we call NALIRIFOX. NALIRIFOX is basically the same as FOLFIRINOX, but instead of irinotecan, what we call naked irinotecan, it utilizes an encapsulated irinotecan called nanoliposomal irinotecan. But for now, we don't really know that NALIRIFOX is any better than FOLFIRINOX. So when I use the term FOLFIRINOX, I could very easily be saying NALIRIFOX as well, and that's probably going to be true throughout this discussion.
And NALIRIFOX, is it better now that it's newer? Is it better tolerated than FOLFIRINOX?
No. The study that was done, they looked at quality of life outcomes, and the quality of life metrics that they measured for patients who were on NALIRIFOX were better than for patients who had received FOLFIRINOX as part of some of the critical trials 10 years earlier. The problem with that assessment is it's really not an apples-to-apples comparison. And the way we use FOLFIRINOX today is very different from how FOLFIRINOX was originally used in the French study in 2011. And my experience and many of my colleagues' experience with FOLFIRINOX and the side effects and how well patients tolerate is really about the same as what was reported in the NAPOLI-3 NALIRIFOX study.
So when a patient comes to you and presents with, a new diagnosis of pancreatic cancer, how do you decide which of these they're going to get?
Yeah. So there have been multiple studies that have tried to ascertain which is better, gemcitabine, nab-paclitaxel, or FOLFIRINOX. And we still, to this day, that debate is kind of raging. And it's gone back and forth. When the gemcitabine nab-paclitaxel trial came out, it was 2 years after FOLFIRINOX, and numerically, the FOLFIRINOX data was better. There was a better survival, a better tumor shrinkage rate, what we call response rate. But there were a lot of caveats to that, including the fact that the patient population who was treated with gemcitabine nab-paclitaxel was a little bit older, a little bit sicker. So again, it wasn't an apples-to-apples comparison. And in fact, over the next 10 years, there were several large sort of registry or database trials looking at the comparison of these two. And there was a lot of discussion that actually they look very, very similar. When the NAPOLI-3 trial came out, it was the first real prospective trial where patients were enrolled and were randomized by the flip of a coin to either receive a 3-drug cocktail NALIRIFOX or the 2-drug cocktail gemcitabine nab-paclitaxel. And in that specific trial, there's no question, and it was a well-run trial, that the NALIRIFOX did better than the gemcitabine nab-paclitaxel. And many people have extrapolated that to say, okay, 3-drug treatment is better than 2-drug treatment. But there have been other studies, still modern studies, that have refuted that, including, for example, there's a Japanese study. Granted, the Japanese East Asian population, we know as a general rule of thumb, just do a little bit differently, tolerate things a little bit differently than the Western population. And in their hands, in their critical trial, the gemcitabine nab-paclitaxel was clearly better than FOLFIRINOX. And then most recently, there was a phase 2 study, but nevertheless a well-run, rather large phase 2 study called the PASS study, PASS, that compared nab-paclitaxel gemcitabine to FOLFIRINOX, and it was completely equivalent. No difference at all in the two groups. So one could really get lost in the debate, and I think that's why we have to factor in other features of the patient in front of you in deciding which one you're going to use. First of all, we know that FOLFIRINOX and NALIRIFOX are a little bit harder to tolerate than gemcitabine nab-paclitaxel. And so we know that sort of an older, frailer patient population probably can't tolerate FOLFIRINOX. And those are the patients that we'll use gemcitabine nab-paclitaxel for. There are certain biomarker subgroups of patients who have certain genetic mutations. If you happen to know that up front, that you might prefer to use NALIRIFOX or FOLFIRINOX. And then finally, patient decision weighs heavily, at least for me when I'm discussing things with patients. if I'm dealing with a patient with stage 4 disease, that we've had the discussion that we can't cure their cancer, and that extension of life is equally important to quality of life, I have definitely had patients that choose that from a quality of life perspective not to be treated with FOLFIRINOX because they don't want to deal with the side effects, including they don't want to deal with the 5-FU pump that they have to wear for 2 days. And so even a fit, healthy patient I've treated with gem-nab-paclitaxel in sort of that patient discussion, shared decision-making process.
So with other chemotherapies, other than the FOLFIRINOX family, you don't have to wear a pump. You can, how does it get administered?
Yep. So all of these chemotherapies go in through the vein. They're all IV. But 20 years ago, it was realized that giving the 5-fluorouracil, 5-FU, it's metabolized very quickly in the body, like within seconds. And so to give a bolus of it, to give a large dose of it, and then just get that treatment once every couple of weeks doesn't do as much as if you give it slowly. And so the way we give FOLFIRINOX and NALIRIFOX is you give the 5-FU slowly over 46 hours, not 48 hours, but 46 hours. And then you have to wear a pump that pumps that in slowly over 46 hours. So patients go home with the pump, they carry it around with them. It becomes their appendage. They get used to it, but it's certainly awkward at first.
It's just amazing how fluent you are in this whole language. I mean, you're reminding me now, it is a language of its own, all of these FOLFIRINOXes and all of the different options. And, sadly, people become familiar with this vernacular.
Yeah, it's true. The analogy that I use for patients with their pump is I say, it's like somebody who broke their leg and they have no choice but to get used to the crutches that they're using within the first couple of days. And it's the same way with the pump.
It's so true. And with the pump, doesn't it actually also make a noise?
It makes a very faint whirring noise. Yes. Some people can get discomfort with that.
Yeah. And so, doctor, I mean, I don't mean to put you on the spot, but when a patient comes to you and presents with stage 4 pancreatic cancer, do you go, is your first instinct to go standard of care, or do you look around for, every other option first?
I definitely consider myself a clinical trialist. And so my first go-to is absolutely to get them on a clinical trial. And I will go out of my way to find them an appropriate clinical trial. As I mentioned earlier, we have the luxury of having, a couple of great centers just within driving distance that might have different trials that patients can have access to. Where I practice, it's actually a real mix of patients, but some of the patients have the means to go anywhere. And so if I've got a friend in, San Francisco who's got a really, really great innovative trial, I'd be happy to refer them over there. So trials are definitely my first choice. It's just that we have so few trial options. And even if there are good trials, there are so few spots on those trials. So I do end up somewhat disappointingly, I'm disappointed in myself that I give standard of care a lot. I wish many more of my patients were on clinical trials. I will tell you that I used the number 4% earlier, that we know that 4% of patients with pancreatic cancer are put on clinical trials nationally. If a center is doing really, really well, they receive high praise if they actually enroll 20% of their patients on clinical trials. And I know at my center at Hopkins, back in the heyday 10 years ago, we were enrolling 50% of our patients on pancreatic cancer trials, which is kind of unheard of. So you're never going to get 100% of your patients on a clinical trial.
I remember hearing about people who were traveling for clinical trials, hearing about patients. But the rub is that you don't just have to go to Portland, Oregon once. I mean, you have to kind of decamp and live there, right?
It's true. Some of the trial designs have become more innovative or more flexible with patient care. There are several large national trials right now that, for example, if some component of their treatment is an experimental component and they don't need to be there for every treatment, then they can get their chemotherapy. If it's added to chemotherapy, they can get their standard chemotherapy at their home oncologist's office, but then just come periodically. But you're right. Most of the trials, you have to be there on a recurring basis. I remember when I was in Houston I was down at MD Anderson for just a year, and I had, there was a whole trailer park of patients who were on clinical trials and used to drive their trailer down there and stay there for months at a time just to be able to stay on the trial.
Wow. Yeah, that's a fact. And so, doctor, what's the takeaway from all of this? I mean, for the patients and their families who are listening, what should they do to be proactive, and particularly if standard of care is all their doctor is offering?
Well, they should definitely talk about clinical trials. They should definitely raise the discussion, acknowledging that many people don't have access to these trials, but they should at least bring that up, because if we don't have a trial for a patient as they're starting their chemotherapy, then we definitely may have trials for them later on in the course of their therapy, either in what we call maintenance therapy or in second line or beyond. So clinical trials should always be a thought if the right trial comes up at the right time. And then I think that, we don't mind patients that come to us with a list of possible trials. The problem is, and this is not the fault of the patient at all, is that the lists that are out there, for example, on clinicaltrials.gov, they're thorough, but they don't really tell you which trials are truly available for that patient at the right time. So that's the hard part too. But yeah, the more informed a patient can be, they shouldn't hesitate to ask their doctor, are there clinical trials either here or nearby that I can go to that might actually give me a better option?
But I think that you make a very good point that I want to underscore, which is you can start on standard of care and you can get some runway with standard of care. I mean, that can work for you. And then you can, while you're looking for your next, vine to swing through.
Yep. And again, many of us are getting that message. I just had an hour-long call this morning. We're designing a new trial with FOLFIRINOX. And actually, we are definitely baking into the protocol that patients can have received 1 or 2 doses of their FOLFIRINOX and then be enrolled in the study. And they're still considered first-line treatment.
That's really valuable. Because you would hate to be blocked, from getting into a clinical trial just because you did something that was the most, it's such a time-sensitive situation that you definitely want to act with alacrity. And then you would hate to be cut out of a clinical trial.
It's true. It's happened to me. In fact, it happened to me recently where a patient literally just missed the window for a trial by hours, and it's really heartbreaking.
Yeah, that is heartbreaking. All right, doctor, thank you. This is so helpful. What have I missed? Is there anything else you want to say about standard of care or any kind of treatment that I've missed?
I think one thing we didn't really talk about is the effectiveness of standard of care. And I won't go into a whole lot of details on numbers and stuff like that. But what I will say, really as a counter argument to that cynicism that I discussed earlier, is that chemotherapy, standard of care chemotherapy, does definitely help patients with pancreatic cancer. In fact, numerically, statistically, the majority of patients, probably about 80% of patients, will have some benefit from the chemotherapy, whether it's FOLFIRINOX or gemcitabine nab-paclitaxel. That means a reduction in their pain, an improvement in their quality of life, an improvement in how they're feeling overall. So chemotherapy definitely can work. It has a time limit as to how long it works for, but it definitely can work.
That is such a great point, and I'm really glad that you're making it. But when you say it has a time limit, can you put a finer point on that? I mean, what does that mean?
That's where I think an individual patient discussion is really important, because sometimes people don't like to dwell on the numbers. And I definitely emphasize the idea that every person is different. And there's nothing about the patient in front of you that tells you if they're going to have a very little benefit from the chemotherapy and their cancer is going to grow rapidly, or if they're going to be those patients who, for reasons that we can't explain, are on their treatment for sometimes years.
Yeah. So in other words, the standard of care can last a long time, but you don't know it going in.
Yep, it's true. So it's really important to manage the side effects, to focus very much on quality of life, and then take it basically one treatment and one scan at a time.
Dr. Michael Pishvaian, thank you so much. Really great information. I'm sure that our viewers will really appreciate hearing all of this.
Excellent. My pleasure. Thanks so much.
Okay, thank you. And thanks everybody for tuning in. I'll see you next time.
Hi, I'm Julie Fleshman, President and CEO of PanCAN. Thank you for listening to this episode about pancreatic cancer treatment. For more information, please visit pancan.org and letswinpc.org. In our next episode, Dr. Andrew Hindefar will join us to talk about how treatment decisions are made and how clinical trials may fit into care planning. We hope you'll join us.